So, hi everyone. Thank you all for joining. This is a webinar from the Global Observatory of Long-Term Care. Specifically, this is the third webinar from the Pain and Care Home Special Interest Group. Adelina Comas Herrera is the director of the observatory, but unfortunately, she isn't able to attend today. My name is Naz, and I work as a research coordinator at the GOLTC, and we'll be doing a quick introduction for the observatory. So, the GOLTC is an initiative of the International Long-Term Care Policy Network. The idea behind it is to harness the collaboration that many of us had through LTC COVID and now focusing on tackling wider long term care challenges. The aims of the platform are for cross national learning. So that's to identify key shared challenges and showcase how different countries and localities are addressing them, and to share evidence and facilitate collaboration. This is an area that's open to anyone interested in long term care. That includes policymakers, people in industry, advocates, care professionals, and academics. So, membership for the GoLTC is free, and I'll be sharing links in the chat during the webinar, as there are many ways to engage with the observatory, including sharing publications, creating country profiles, and joining any special interest groups. In terms of our next events, we have a webinar coming up next Tuesday, actually, from the Quasi-Experimental Methods Interest Group, followed by, on Friday, the 22nd of November, a webinar from the Social Protection in Southern Africa Interest Group. And then we have one on Monday, the 25th, from the Data Science Interest Group. And finally, for November, we have one on the 28th of November from the Strengthening Responses to Dementia Interest Group. Again, I'll share all the relevant links within the chat, but for now, I'll pass it on over to Julia for the Pain and Care Home Special Interest Group, and they can begin their webinar.
So, hello from my side. I hope everybody can hear me. I'm Manuela Hödel, and together with Sandra Zwakaun, and Sandra, hello, and a colleague, senior from UK, we created this special interest group. Sandra, maybe you want to say some words also?
Yes, also on behalf of me, warm welcome, this special interest group. And as Manuela said, well, we had some previous meetings and this is one of them. So we're happy to share, well, all kinds of themes and topics related to pain and care homes. And this is one of them. So, and thanks for organizing, of course.
Thank you once more. The first webinar was on pain assessment in care homes, and we had a great talk of Wilke Achterberg, focus on the PIKE. He also told us that there will be a new PIKE in the future, so we are still waiting for that. In the second part, in the second webinar, we were focusing on the management, so what is done, and there we had two great presentations about all the interventions in care homes in different countries. And now at the end, we are at the outcome. So what to measure when you are focusing as a researcher on pain in care homes. And that's why I invite, or we as a special interest group invited Julia. And I give just now the floor to Julia to introduce herself and her interest group or her consortium that stands behind this Cure outcome set. Julia, thank you very much for doing this presentation.
Thank you very much for having me. So I'll introduce myself first. My name's Julia Bova, and I work at the National Institute of Health based in the US. So if I seem a little tired, it's because it's very early for me. So just be patient. But I'm presenting today on an international study that I did alongside colleagues in the EU to develop core outcome sets for the entire spectrum of pain, acute to chronic pain, recurrent pain, and chronic pain. And I'll go over those definitions in the presentation today. So our consortium seems like it has similar goals to the GOLTC. We were a consortium and an agreement between the National Institute of Health in the US and some European colleagues, many based out of IMI Pain Care, if anyone is familiar with that group in Europe. And the goals of the group were really to advance pain research, both research and clinical practice, improve the lives of those living with pain, share knowledge across borders, and collaborate on studies, translations, biomarker development, and the testing of different treatments. One of the main focuses of the group, which I will be presenting on today, is data sharing and harmonization transnationally. And so this group basically tasked us with creating an overarching set of core outcome sets for pain. So core outcome sets are basically an agreed upon set of both outcomes or domains, and then the measurement tools to assess those domains. And generally, they're agreed for a certain health condition to be measured in all studies. And they usually include only the most minimal and critical domains, up to about 5. And then the difference between domains and outcomes is that domains are basically what you measure in a study, or sorry, domains are what to measure in a study, and then the other part of core outcome sets are the measurement tools, and that's basically how you assess the outcomes that you choose to measure. And one important thing to mention here is that domains that are not included in the core outcome sets that are agreed on for a health area, they're still very important to be measured concurrently by the researchers. So if there's 5 domains in a core outcome set for fibromyalgia, for example, there might be additional domains that the researchers choose to measure just based on their study goals or their populations. And the main reason to use core outcome sets is to have standardization. And we want this to be consistent across research and clinical practice for the goals of our consortium, and to be able to aggregate research across studies and clinics. This way, research can inform clinical practice, and then clinical practice can inform research. And this allows for being able to gather larger amounts of data and having stronger statistical analyses from a broad pool of participants. And the role of researchers in this process is to assess biopsychosocial domains. And what I mean by that is ensuring that you're not just measuring pain intensity, but you're trying to measure the entire experience of someone living with pain, biologically, psychologically, socially. And we'll get into more to that later. And then lastly, but probably most importantly, is that you're measuring domains that are important to people with lived experience, because of course, they're the ones that are most impacted by the health condition under study. So a Delphi method is basically an iterative consensus method that is often used to develop core outcome sets, where you bring together a group of stakeholders, and over a series of surveys, they reach consensus based on cutoff points that they're utilizing in the study to vote on what domains they think are the most important. As I mentioned, we developed core outcome sets to measure in research and clinical practice, and these allow comparison and analyses across and within pain areas and health conditions. And our goal was to be able to take data from around the world related to pain and have better translation of research to clinic. And also to be able to have evidence-informed treatments for those with lived experience, and provide a holistic assessment of how people experience pain by measuring outcomes that people with lived experience believe are most important to them and their experience living with pain. And then the flip side of that is to be able to have medical professionals understand their patients' experiences and then be able to tailor those treatments accordingly. So the way that we started this process was that we identified researchers with previous core outcome set experiences who had developed core outcome sets for any pain condition and any pain-related condition. So there were many researchers who had developed core outcome sets for chronic pain, some who developed them for acute pain, and then we brought together many other researchers from like headache, fibromyalgia, pelvic pain, dysmenorrhea, areas such as that. And we brought together about 150 stakeholders to have a meeting where we basically asked everyone, do you think this is a valuable study to pursue. Would the field benefit from having a core outcome set for all of these conditions combined? And we also included many patients and patient advocates in this meeting, where we presented them with our study goals and asked them whether they agreed to move forward with it or disagreed. And then when we had this meeting, we also split people into different groups based on their expertise, whether it was a researcher developing a core outcome set or a patient or a person with lived experience who had lived experience with one of these areas. And that's how we split them up to have a discussion on the study goals. Overall, we had about 150 attendees at the meeting. We had people with lived experiences. We had researchers who had developed studies themselves for core outcome sets. And the other category is basically government staff from the National Institute of Health. There were a few European colleagues from the industry, and then we had some policymakers involved. And they weren't participating in the study, they were just there at this meeting to give feedback. And then I also wanted to go over the categories that we developed. These were developed from research and from advice from our advisory committees. So as I mentioned, we wanted these core outcome sets to be able to be used in research and clinical practice for any pain condition, no matter where it is on the spectrum from acute to chronic pain. And so acute pain was any experience lasting up to a few weeks. This is usually post-surgical pain or pain during surgery. Then there's a group that we labeled the transition from acute to chronic pain. There's a lot of research being done at the moment on what exposes someone to developing chronic pain if they already experience acute pain, and that's often from post-operative recovery. Then the recurrent episodic pain are pain experiences that last a short time, but they recur over an extended period of time, something like headache or sickle cell disease. And then chronic pain, which I think is probably most relevant to this group today, the definition there is pain lasting more than 3 months. And I shared these slides with Manuela so she can send them out, but the way that we ran our study was that we split individuals into 2 groups for voting purposes. We either put them into person with lived experience group or an other group, which included healthcare providers and researchers and some health technology assessment experts. The reason we split them into 2 groups was because we wanted to make sure that we weighted the votes of people with lived experience equal to the votes of researchers. And we had 3 rounds. In the first round, they voted in 4 different groups. And they started with about anywhere from like 30 to 60 domains to vote on. So it was a pretty comprehensive list because the literature was so robust. And then it was a basic Likert scale of 1 to 9, where the 7 to 9 meant they thought it was important to include in the core outcome set. We also gave them the opportunity to suggest any other domains that they thought were missing in this round. And if greater than 70% of all respondents, so the healthcare providers or the people with lived experience, voted the domain as critical in that 7 to 9 area, then we proceeded it to the next round. And then any domain that was suggested from greater or equal to 5% of the group, we also included that. So that meant that during round 2, because of the suggested domains, the lists were still pretty long, so we needed a bit more exclusive criteria. So we had them vote again on that same Likert scale. And this time we had, if more than 70% of both groups combined voted the domain as critical, then it proceeded to the 3rd round. And then in the 3rd round, to make sure that we were actually able to reach consensus by this 3rd round, we actually had all participants just rate their top 5 domains of the domains that were remaining. And then from those ranking, as you can see here on the right, we basically averaged them from both groups to come up with a final list of 5 for each group. And there, I will provide a QR code right here that links to our study if you have more questions about the process itself. Delphi studies can be a bit complicated, especially because there's no like perfect way to do it. And we relied heavily on our advisory committee to help us make these decisions, especially, for example, when we switched the type of voting from round 2 to round 3. So these were our demographics of those who participated in the study. Overall, we had about 350 unique individuals who participated, and I say unique because we probably had 600 voters spread over the groups, but we had many people with lived experience that voted in several groups. Because, for example, someone with acute pain is really hard to capture because they might not be experiencing acute pain in this moment, but they might have experience with it in the past. So we asked many of our participants to vote in several groups. But importantly here, you can see that, as I mentioned, we split the groups into the researchers, clinician, and others, and people with lived experience. And we had about equal participation from people with lived experience in all of our groups, which is one of the things that made this study most unique. And as I mentioned, it was just a big study, 357 people from around the world participating. And then we had a pretty decent amount of geographic diversity. And so what this map is basically showing is from North America. This is the acute group, the transition from acute to chronic, recurrent, and chronic. And this is how many people participated in each round. So row 1 shows round 1, round 2, round 3. As you can see, we had representation from every continent, but it is heavily weighted towards North America and Europe. And that is largely because of where the research on core outcome sets is coming from. And then we relied on our networks from our patient advocacy networks from North America and Europe, and we asked them to recruit other individuals for the study, essentially using snowball sampling, which meant that a lot of the participants, again, were limited to North America and Europe. And so these are the final core outcome sets that were agreed upon by each group. We really encouraged participants when they were voting to try and think about measuring pain holistically, so including not just like pain intensity, but considering the social parts of pain, the biological parts of pain, and the psychological parts of pain. And so for the acute pain, we had pain intensity, and pain interference that were included. We split these into domains and subdomains. So if pain intensity made it into the final round, by default, we included pain as a domain. That's just how they are categorized in the literature and from the groups that were advising us on the study who had more experience in developing core outcome sets. And then this group also included physical function and quality of life. And then we have a set of domains that we think should be considered. And this basically just means that in the final round of voting, it made it into one of the group's top 5, either the people with lived experience or the researchers, but not both of the group's top 5 when we averaged them. So we included it as something that researchers and clinicians could consider measuring because it is important to the participants in the study. The transition from acute to chronic pain also had pain, which encompasses pain intensity and pain interference, as well as physical function and quality of life. And then these were the domains that we think should be considered: sleep and psychological functioning. Recurrent episodic pain had pain temporality and pain interference, as well as pain activity limitations, health-related quality of life, which then includes quality of life. And in this group, they didn't have any additional domains to consider. And then lastly, for chronic pain, this group voted on pain, which includes pain intensity, pain interference, activities of daily living, quality of life. And these were the domains that could be considered: physical function, psychological function, and quality of life. And for definitions of these domains, we had a pretty robust process for coming up with definitions. We either took them directly from the literature, or many studies actually didn't define domains when they had voted on their core outcome sets. So we did our own research on definitions, and then we had both our advisory committees and our steering committee approve those definitions. And those will be in the paper that, again, I have a QR code to at the end. So some of the strengths of this study, as I mentioned, it was a really large study, and we were very particular about including at least 50% of participants as people with lived experience, because a lot of core outcome set studies prior to this had not done that on their panels, or they only had a few representatives that were patient advocates. And we did this just because this means that the core outcome sets are more generalizable and meaningful for those most impacted by pain. We had a lot of diverse representation in terms of nationalities, gender, professional backgrounds, clinical specialties, and research expertise. And this is because I mentioned that we had a meeting prior to the study where we brought together 150 stakeholders to ask them if they agreed that this study was a good study to move forward with, but also we asked them to recruit participants. And so we asked any patient advocate to recruit up to 20 patients from their networks, and we asked any researcher or clinician to include 10 individuals from their core outcome set study panels. But when we asked them to recruit other researchers, we told them to only recruit one individual from any specialty so that we had a wide range of specialties represented. And we had a pretty high response rate for this type of study, about 75%, depending on which specific group we're looking at. That was partly because of all of the effort we put into generating input for this study. And then we also allowed people to vote in round 2 or 3 if they hadn't voted in round 1. They were invited regardless. And then our advisory committees had a very robust involvement. We had 2 advisory committees. One was made up of researchers with experience in outcome development and Delphi studies from OMERACT and COMET. And then we had an advisory committee that was just patient advocates that we consulted a lot with, just to make sure all of our materials for the study were accessible and understandable to someone who may not have otherwise participated in a study like this before. Okay, and then our limitations and challenges. As I mentioned, we had patient advocates recruit other patients and people with lived experience from their networks. So that kind of meant that they ended up being people that were connected to the research realm, because they were either patient advocates that we already worked with at NIH or that our European colleagues worked with. So we think that this limited a bit the socioeconomic and racial diversity of the panel, just because of the types of advocates that tend to run these organizations and already be connected to the research field. And it was an international study, but we only were able to offer surveys in English just because we had no funding for the study. It was basically just the NIH staff that were working on this study. And then, as I mentioned, literature for core outcome sets currently is very, very heavily weighted to North America, Europe, and then some from Australia and New Zealand. And that meant that when we were pulling in researchers for this study, we were pulling in researchers largely from North America, Europe, and Oceania. And so while these core outcome sets are very robust and we hope that they're used internationally, it's important to note that they are much more generalizable to the studies that were heavily represented in this study, so North America and Europe. And we think that the overall, independent of this study, there's a really strong need to have studies from lower income countries, lower and middle income countries, have their own core outcome set development and be brought into studies such as this. And then lastly, this is one area that's also very difficult. As I mentioned, a core outcome set encompasses the domains or outcomes to measure, and then the assessment tools or the questionnaires. And our study did not develop the patient-reported outcome measurement, and that's because when you look at the different questionnaires that are validated in certain populations, it's very difficult to then try and validate those across all of the countries that we worked in this study. So where we stand right now is that we are recommending the domains that were agreed upon in this study And then we're leaving it up to individual clinicians and researchers to determine how they want to assess those domains and which questionnaires they want to use. And so the implications for research are that researchers can use questionnaires to assess the domains presented here today, depending on which pain category of research their research falls into. And as I mentioned, these are very much meant to be used in conjunction or alongside other outcomes that the researchers are already measuring. And then the goal is to have data shared to a repository in the long term so that study results can be shared across borders. So for example, the same measure being used in a health system, these results can then be aggregated and you can access data from a broader range of individuals from just the study that you did. And this can allow for those types of comparisons and statistical analyses that I mentioned earlier. So this is a QR code that after the slides are shared, this will link to the study results in the paper that we published. And then in terms of this group, I think that measuring outcomes for chronic pain that are relevant to people with lived experience could be really important. And again, using outcomes that are biopsychosocial in nature is very important given the overlapping health and psychological conditions in long-term care communities, and being able to improve pain assessment by using core outcome sets that were agreed upon by so many individuals across different nationalities, and then just having an opportunity to harmonize data with other long-term care communities and populations that are relevant to this project. And then my last slide is basically just an acknowledgement slide. This study occurred over about 2 to 3 years. When you consider where we started with the literature review, it was a huge effort. And so we had co-chairs both from the NIH and the US, and then we had advisory committee members and NIH staff and IMI pain care members. And this QR code links to our website that has all of those that agreed to be named in conjunction with the study. And I have a few other slides here, but I'll just stop so that I can answer any questions. And then if the PDF of the slides are shared after this, it has a bit more information about the details of our processes.
Thank you very much. So there's already the first question in the chat. Julia, the question is from Julia, which instrument do you use for the Delphi process?
Yeah, so we used SurveyMonkey, if you're familiar with it. The reason we use SurveyMonkey is because there are some initiatives that have specific software for Delphi studies. They're very expensive, and as I mentioned, we didn't have funding for the project. But more importantly, those softwares didn't allow us to basically tailor the study to our own needs. We had a lot of people from around the world, and we had a lot of patients participating. So we actually included a short webinar on like what the goals are of the study, what core outcome sets are, and then we had comprehension questions. And then each survey round, we also included all of the results from the previous survey so they could see them when they voted. And then we had pretty clear instructions. And again, we had like visual aids so that someone who might not have experience with core outcome sets had as much information and as much help as possible to understand so that the results of their voting were meaningful. And because of that, we wanted to use a survey tool like SurveyMonkey that allows you to kind of just do like whatever you want when you're designing the survey. Whereas the softwares like Delphi Manager, I think they're really helpful for organizations.
We're not allowed to use SurveyMonkey.
You can like email everyone automatically. It includes all of their responses when they log in. So there are benefits to a survey tool like that, but it just wasn't as helpful to us. That being said, it provided a lot more work for us to create our own surveys on SurveyMonkey.
Okay. Thank you.
Yeah.
And another question, did you have to apply to ethics committee?
We did not, because we were just gathering survey data. Do you mean like, did we submit to the IRB?
Yes.
We didn't have to do that for our study. we did have to include a caveat on the study that we would, all the data was disaggregated, and then we deleted any personal identifying information for the study participants once it was over.
Okay, thank you.
Then another question, when we are talking about, for example, the pain domain, this is also an open question and not only for Julia. It's more, also a personal question, because we are planning a study currently and we want to include the core outcome sets in care homes. And when you measure pain intensity and pain interference, any ideas or any validated questionnaires you can recommend?
As I mentioned, we're not developing measurement tools, but we have started to take not like a formal literature review, but just for our own purposes, kind of like an informal review of some of these questionnaires. There are questionnaires that are developed for pain intensity and pain interference. The NIH has a program called the HEAL Initiative, the Helping End Addiction Long-Term Initiative. And this is one of our largest funded programs. Within that program, we do have a common set of outcomes or domains that all researchers that involve human subjects are required to measure. And there is the brief pain inventory, the BPI, which I think is like a pain intensity measure. When it comes to validation, though, it's still a problem. Like when we did our review, for example, we have a lot of populations in those studies who struggle with opioid use addiction, and they're not necessarily validated in those specific populations. Most questionnaires that we looked at were validated in we're basically validated in like white women, not even necessarily pain patients, for example, like depression and anxiety. So there's a lot of work that needs to be done for validation in those populations. And to be honest, that's why we couldn't move forward with the PROMS part of this study, just because of what kind of effort that is and the funding available.
Enrica just said, Enrica, maybe you can unmute.
Yeah, I'm not sure I'm answering the first of your questions, but basically I am an economist, and I've been studying the relationship between pain and socioeconomic status among all the non-institutionalized individuals. I'm using a survey for the US, which is the Health Retirement Survey, and for Europe, the Survey of Aging Retirement in Europe, which is the European sister of the American survey. I don't know if you guys are familiar with them. And but I only have two very general questions that I can use, that they ask and that I can use. So they ask whether people are often troubled by pain. Yes, Julia. And then as far as the intensity of the pain, they just ask how bad the pain is most of the time. That's why I was curious about the questions that Julia was mentioning.
This might be a little US centric, but we have a repository of questionnaires for that program I mentioned that include the required ones and then supplemental ones outside of the required domains that researchers within this specific study are using. I think there's a group from Sweden in there that has some questionnaires. I do not ever remember seeing something that was validated in long-term care patients, though, unfortunately.
Thank you so much, Julia.
Yeah.
Any other questions, comments for Julia to the core outcome sets? I was also wondering, because you were talking about that the core outcome set can also be not a base, be linked to the pain assessment. Can you maybe go a little bit more into depth? What do you mean by that?
That the core outcome sets are related to pain assessment.
You had it on the one slide, and I'm not sure what you meant by that. I think it was implication for research. I'm not sure right now.
I think what I meant by that was just that for these core outcome sets, we called them overarching core outcome sets for pain to span the pain continuum. And our hope is that the core outcome sets are used to assess any pain condition or any pain related condition where pain is a major outcome of that study, basically. And so these outcomes are basically just meant to be used to assess pain holistically. So not just pain, but these other facets that go along with pain. I think I'm answering the question. Otherwise, I'm not sure what I put on there.
Yeah, thank you for the answer, because it was really interesting. I think it was in the first webinar we had about pain assessment. We were talking about the PIKE. Wilke Achterberg showed us how it was developed. Then we had another colleague, Patrick from Brazil. They made the validation of the PIKE 15 into Portuguese. And then we were discussing that some of the pain assessment, some of the pain scales, doesn't matter if it's self-reported or if it's proxy reported, they do not catch this holistic view, as you've mentioned. That's why it was, okay, pain outcome, pain assessment. It was for me right now the link to the first webinar we've had, because we were already talking about if this pain scale just are too narrow, because they miss like the social part, as you have it inside in the core outcome set, the psychological part. I think this is really interesting, because this would be my idea, and we can discuss that, to go on with that thinking, how to improve these pain assessment scales in a more holistic way, based on the core outcome set, to open and close more or less the research questions.
Yeah, I could not agree more. And our experience, including patients in the study, and then also having discussions with patients at a conference about a year ago, I presented on this, and then we had a discussion about basically measurement tools and how to move forward. And a lot of people with lived experience that were part of that conference and that discussion emphasize that they're really unhappy with the pain scales as they stand. And most often what's important to them is their quality of life and their activities of daily living. So it's not how intense that they feel they experience pain on a daily basis. It's what are they able to do, or what are they able to not do that they want to do because of that pain that they're experiencing. And that's why, like, the psychological functioning, the activities of daily living, and the quality of life are such important domains to include in those core outcome sets.
Can I respond to that?
Yes.
And I think especially because I think your criticism is fair enough, because I think all these pain skills that we have at the moment are very narrowed, because they are all observational skills. Like, you step into a room and then you observe for a couple of minutes and then you complete it. So that makes that they do a consequence is that they are not holistic, because they don't take into account like what is influencing your social activities or interaction, or how does this influence your psychological well-being. So this is already a restriction of the tools themselves, I think, by the way they are designed, by the way they are supposed to be used in way of observation. And I know, because I think well, at least perhaps more of you were involved in the PIKE, but I know Pat was, and I was as well. And I think they started by looking at what is most frequently occurring. So that is why they focused on facial expressions and body posture in a way. And they left out, like, what does it mean for social responses, or yeah, withdraw or these kinds of things, more social emotional behaviors. I think they were less emphasized in these procedures. So I think you're fully right about that. That is a restriction in a way that is not so holistic as we would like it to be, I think.
Yeah.
Mhm.
Yeah, and I'm actually not familiar with the questionnaire that you guys have been referencing, the Pike. So if you could put it in the chat, maybe I could look it up for additional text.
It was developed, I think, based on a European funding scheme, because
Okay.
there were a lot of scales available in Europe, and depending on which country they originated, for example. So that is why they decided to compare these items of all these skills that existed, and then based on that, they try to extract or develop a skill that is translated in several European languages. So I fully understand why you're not familiar with it, because it's quite a European approach, I think. But here it is. It's a 15-item observational skill.
Okay. Very
I
interesting.
will put the link in the chat.
Okay, thank you. And I saw Julia's other question in the chat about including any people with lived experiences with cognitive impairments or their advocates. For that question, I have to say we didn't ask them on the survey if they had a cognitive impairment. So I can't say whether yes or no. My assumption is that we probably didn't have representation from those with cognitive impairments, just based on the fact that the survey, the way that the survey was designed. I don't think it was like a read aloud survey. It was basically like reading, answering questions. There were some visual elements and the video, as I mentioned. But I'm not sure I can answer that question scientifically. We did include patient advocates or advocates of people with lived experience. So if you were a caregiver of someone with living with pain, you were included in our people with lived experience category. So in that sense, someone could have been a caregiver for someone with a cognitive impairment, but we didn't collect that data.
This was a great presentation. Thank you so much for sharing it with us. If no one has any other questions, then we could wrap up a little early and give people some time to grab lunch.
Yeah,
Sounds
thank
good.
you for having me. And as I mentioned, I sent the slides to Manuela, and I'm happy to continue this conversation offline if anyone has questions over email or in the future, other collaboration opportunities come up. I really appreciate you guys inviting me and getting a chance to get this word out a little bit more. Obviously, this is just an initial step in the process, and there's much more work to be done.
I would say I'm delighted on behalf of the steering group for pain in care homes to the 3 really great webinars. And it's interesting that we started with the assessment and now come through the management to the outcomes, come back to the assessment discussion. So for next year, I think there is still a lot of things to discuss, to see. And yeah, I hope we will see you next year again when we will share our new webinars. Thank you very much.